Well, actually, that was the question you just answered about the difference between orthopedic and plastics. But you just answered.
Oh no, that's okay. Thanks.
Thanks.
Yeah, no worries. Um, so yeah, another question is any tips for tailoring a CV for a trauma fellowship, to land a trauma fellowship? So I
At
think just
trauma.
sort of, again, just like general, if you want to be, if trauma's your thing and you want to get really good at that, what can you do to tailor your CV for that?
Well, you have to leave yourself enough time to plan a fellowship. Most fellowships are going to need to be planned at least 2.5 years in advance. I think if you want to try a trauma fellowship, again, identify where it is that you want to go to. Make sure it's a recognized high quality fellowship. Shock Trauma in Baltimore, Harborview in Seattle, the Vancouver. Now, on the mainland in England, there are quite a few good trauma fellowships in England. You'll need to apply through their application program. Part of that application, you need to show an aptitude to trauma. You need to show the cases you've done, where you have worked, and been in contact with the unit to where you're going to introduce yourself and let them know that you're interested. And I do think, again, like everything else, if you have got some publication showing that you have an interest in trauma and you've done some research in that field, that would stand you in good stead.
And another question we have is, so yeah, about run-through trainings. So in neurosurgery and cardiothoracics, they have run-through training. And for those who aren't familiar, that's where you complete your foundation or intern year, and then you go in and then you won't have a competition to get into higher surgical training. Do you imagine there will be a run-through training for trauma and orthopedics within the UK?
There is. I mean, there are several places in the UK that run-through training. It wasn't introduced in Belfast because we've got serious reservations about it. The reservations being that once somebody comes in at a very early stage in their surgical career, you've really got very little way of getting rid of them if they're not competent. So we did not opt for a centralised run-through programme, but there are centres in England and several training programmes that have run-through training.
Okay. Another question is, oh yeah, so I had a question, what was the NHS resource? So there's the NHS audit book, which is talking about, it's a resource of like suggested audits you can do in surgery. However, the other one that I found useful was the self-assessment guide. That's if you're applying the core surgical training, and if you search up core surgical training, like how to get on it, there's loads of resources online. And again, if you're in Ireland, it's just such a good resource to have. And I wish I'd seen it when I was in my younger years, just so you have an idea of what you can aim towards. I think that's what you meant by the NHS resource. And let's see what else there is. Yeah, and a question. So you'd recommend starting research in orthopedics as early as possible. How early would be too early, and when should one start research in orthopedics?
Well, I mean, from my point of view, as a first year, I did my year as an anatomy demonstrator. I was then in a general surgical SHO attachment in a general surgical unit. In that unit, I managed to get a case report. So I tried to aim to see if I could get one case report for each 6 months to try and put out and get it published. In terms of my research, I took a year out to do an MD thesis in Perthes disease. I did it relatively late. A lot of folk will opt out to do a PhD or an MD thesis before they get into their training job. I did it whilst I was in my training job and took a year out. But the benefits to me of having those publications and presentations stood me in good stead when it came to both my fellowship and my consultant's post. So when you do it, it's difficult to say. The vast majority of folk will undertake some form of research in and around the time they're thinking of applying for specialist training.
And again, related to just research, Molly was asking any tips on how to approach a consultant to get involved with research, or any tips in writing a letter, or say if a student was to approach you and getting involved in research, what make
well, I mean, there are, in the unit in which I work, there are individuals that have always had a predisposition for publication and research, and I would try and steer the student towards those individuals. I mean, I have a research pedigree to a type, but I don't do it on a regular basis. So I certainly think it's worth talking to some of the junior doctors or who are those who are in training to ask who did they do their research with, what was the research that they did, I think you can make yourself available for people who've got ongoing audit projects or whatever, to just be the donkey, if you like to do the donkey work, because you'll get your name on the publication. You may not be the first author, but your name is on the publication. I think it's difficult. Every unit will have individuals who either are or who aren't interested in research. And if you approach one of those, you're going to get nothing out of it. So I would certainly talk to the juniors. I would outline your interests and say, listen, I'm going to get a research project going. Who do you think I should talk to about it, and take advice from them?
Thanks very much. So just from the chat, does anyone else want to ask any questions before I finish up? No? Yeah, okay, so one more. Yeah, so this is one thing I sort of noticed, this question here about if you're in first and second year and interest in orthopedics, what can you do at that stage? My personal opinion is in first and second year, I noticed like maybe some of the people who are like graduates coming in first and second year, they're quite keen to get started and get research as soon as they can. I felt before your clinical years, it's really hard to sort of build on your CV in terms of research at least. But I suppose other stuff you could do would be maybe just getting involved within, say, your local like orthopedic society or your surgical society. Or Mr. Kealey, would you have any thoughts on that? And if you're in first and second year?
I think it's very difficult. I think you're quite right. Coming in as a postgrad, if you're coming in on a postgrad course, you've had the experience, the life experience, in a slightly different place. If you're coming in directly from school into first and second year, I would concentrate on getting your exams done and get into clinical training before I would worry too much about getting a career in orthopedics.
Yeah, I'd agree with that for sure. Like it wasn't really, I'd sort of always had orthopedics in the back of my mind since first year, but it was only really since third year that I sort of shifted it up a gear, just because that is when you do get into clinical placements. And so I think once you're in third year and you're starting to get your clinical rotations, you start to get a feel of what you might like and what you might dislike. So I would say it's obviously good if you do get ahead, but my personal opinion is it's very early to be involved in first and second year. But you know, each to their own.
Yeah.
And so just one more question. So would more let's see. Okay, yeah. So just another question about research is, does it have to be surgical research to count towards your surgical CV?
No.
No. Yeah.
If you publish or you present, it doesn't matter what the field is. It's you've made the effort to do something.
Yeah. Yeah, I'd agree with that as far as I know. So I think I'm just going to finish it up there. Okay, yeah. So this is just, again, this is my very personal, very subjective pros and cons. Is the hours are challenging, but at least this is spent in theatre. It's not spent in outpatient. Surgeries you do are, or sorry, let me see. Yeah, so the cons are the hours are challenging. There's definitely need for diversity, just in the diversity of background of people on it, like involved, and also in terms of like male to female balance. But as Mr. Kealey was previously saying, there is more female trainees getting involved year on year. So I think anyone watching this now who's the complete training, by the time they graduate, it would be a lot more balanced than it is now. And likewise, 10 years ago, it's improved from then. So I think it is just catching up with the times, but it is going to slowly but surely balance out. Another con is sort of a knucklehead perception of orthopedics, that it's ran by rugby players. They don't know any medicine, and they're kind of jocks. And there's even a few publications that have like talked about this. And even though there is, I think, Ms. Kealey, would it be fair to say there is sort of an orthopedic stereotype? Would you?
Oh yeah, no. I mean, we're all, we're all viewed as being, really having the brain of Homer Simpson and the build of King Kong. I actually, I would, obviously not unsurprisingly challenge that perception, but yes, most people think that we don't think, and we're fairly sort of belligerent.
Yeah, but yeah, there's a stereotype. With that being said, I also think like my personal experience, and I'm sure you'd agree with this, is orthopedic surgeons are definitely team players. And even we compare to, I don't want to pick in any other surgical specialties, but I've always felt that orthopedics, they're very supportive of their team, of their teammates and everyone on the team. And that isn't necessarily true in other specialties. So I'd say even though there is that maybe knucklehead perception, they are still definitely team players.
No, I mean, I have to say, I mean, like all specialties, you will get those that are sit outside the bell-shaped curve. I would tend to sort of feel that as a specialty, we tend to be can-do as opposed to can-don't. I mean, I think we would try and start with that type of attitude. I do believe, for the most part, we're team players. I think we understand the need to build a team and support a team. So I would, I mean, and I think for that reason, we tend to remain a popular surgical specialty because people can see the benefits in what we have to offer.
And just my last little point there on my pros and cons list was that orthopedics does have little management. And I think that can be a pro or a con, depending on who you ask. But would you say it's fair to say that what you do as an orthopedic surgeon is very removed from what you're taught in medical school?
No, I think it's very easy to think that all we do is operate. If you consider the elderly fragility fractures, we have to work very closely with the care of the elderly, the osteoporosis team to try and, in preventative strategies. With rheumatoid disease, we work closely with rheumatologists to try and prevent joint deformity and improve joint deformity. We have to work closely with our endocrine physicians for the management of diabetic conditions. Whilst we may, our practice is very varied, and at certain points it does link up very closely with other medical specialties that we have to work with to allow us to be successful in what we're trying to do.
Fair enough, thanks. And okay, just the very, very last question, because I don't want to take any more of your evening, Mr. Kealey, but I have a question on your Perth's disease research.
Perth's? Perths, yeah.
Sorry, pardon my pronunciation. So someone's asking what part of a degree were you doing, and could you expand on what this was a little bit more?
Yeah, no, that's no problem. It was called an MD thesis, so it was a doctorate of medicine. So my basic qualification is MB, BAO. I then took a year out to do an MD thesis. And really at the time that I took it out, some work had been coming out of some centres in North America suggesting that a clotting abnormality in children may predispose them to developing Perthes disease, thrombophilia. So we in Northern Ireland at the time had one of the highest incidences of Perthes disease anywhere in the world. So my research involved sampling bloods off a huge subset of healthy individuals or healthy children who did not have Perthes disease, looking for underlying thrombophilic traits. And I also reviewed all the cases of Perthes disease, looking at the social background they came from to identify whether any social parameters may predispose these children to developing Perthes disease. So certainly there did seem to be a link between children living in lower socioeconomic groups and the subsequent development of Perthes disease, and that was very much highlighted in our demographic study, and backed up what had been found in Liverpool many years ago. Thanks.
And also, just a few people are asking for clarification on an MD. So in America and Canada, an MD is just your medical degree, but over here it's an academic qualification. So correct me if I'm wrong, Mr. Kealey, but you have a PhD, which typically lasts 3 years, and is supervised. And then an MD is lasts 2 years and has less supervision than an MD. But the point is, yes, it is like it is an academic qualification. An MD in Ireland and the UK is like a PhD, but undertaken by doctors.
Yeah.
Okay. So I think that's everything. If I'm going to finish up now, and just to thank everyone for joining us. It's our first talk, so please keep in track on social media online to see when our next one is. We've got ones coming up on training in the UK and Ireland and North America, and also women in surgery, as well as workshops. And I'd really appreciate if once you do this, first thing you do is feed up the feedback presentation form. It's super handy for us planning our next event. But I think that's everything. Thanks very much, everyone, for listening. And thank you, Mr. Kealey, for your insight and talking to us.
No problem at all. Cheers now.
Thanks. All right, see you now. Bye-bye.
Bye, bye, bye.